All right, so perineal access technique. So why and when? Well, we've seen many times throughout the conference why we need it and how retrograde access can help us. Why the perineal? Well, it may be the only vessel that you have left to access, or you may want to spare the AT or PT by going into the perineal. Furthermore, it gives you straight access usually to the retrograde approach. So we use it if I can't cross it, we can't cross it from above, and the intervention is indicated, and we think it's best for success, and that's not infrequently. So some basics for perineal access, you, in my opinion, need access from above first, both for angiograms to help in the perineal access and for ultimate definitive treatment. Remember that the artery lies under the interosseous membrane right next to some veins, so this is one-time body. It's hard, at least for in our mortal hands, to use ultrasound because of that. Instead, we use road maps, dynamic angiograms, or the calcium. And then we stay low with 018 system and simply wire it from above, externalize it, and then work from above, as we'll see. So setting up for perineal access, first, I think it's important to ask yourself, is it indicated? In other words, if the patient's been on a table for 2 hours without a Foley, maybe you don't want to do it then, but otherwise, if they're informed and ready and you have a good treatment plan, then we go ahead and proceed. The way we do that is we'll, again, have an interventional sheath from above. We will prep everything, and then we will stay low with micropuncture needles and 014, use the 018 wires ready to go. We set up the image detector for the perineal access, and then we're ready once we give the angiograms. So how do we do that? Again, we first do an angiogram from above. One, I want to see where I'm going to access it, and two, I want to see how long does it take dye from above to get down there, so I'm not standing on for 10 seconds at a time. Once we determine that, we set up the camera at the access site, and we mag up, and we get to work. You're going to rotate the II so that you can separate the tibia and fibula. It's usually going to be an ipsilateral 30 to 40, somewhere in there. We will then do an angiogram or a road map from above, and aiming at that, we'll aim our micropuncture access and the ipsilateral wire with a pre-shaped wire ready to go. Once we see the blood return, as you've seen here, we carefully advance the shaped and ready wire. Now, if you're going in on that road map or angiogram in the ipsilateral view and you're not hitting it, then rotate your camera to a contralateral view to assess the needle depth, and I'll show you examples of that in a second. And then you can adjust your needle depth based on that and then advance your wire. We like 018 wires usually, or sometimes 014 if you need to get it up. And then we go with 90 centimeter 018 catheters, cross the lesion retrograde, and then finish from above. Again, we externalize, as you've seen Andre teach us with the FR4 bright tip, place an antegrade wire, and then I usually have the tech hold pressure while we keep working. And if you need to, at the end, you add a balloon tamponade from above. We don't really need that very often. Here's just a picture of that, the vein surrounding it and the interosseous membrane. So here's how, this is a left perineal access, so this is an LAO view, and here's that road map that we'll use. Now, this one we missed, but you can see how deep I was with the needle, so you use that, you make a road map, pull it back, and then advance your wire up here. Here's a dynamic angiogram. You can see, again, notice how we separated the bones out. That's the view you want. And then here's the other view is the contralateral for depth. I want to show you a few cases where it's really helpful. This was one of our vascular surgery partners did a right femoral endarterectomy and did extensive endo work, but then she had acute limb ischemia that night. You can see when he did the endo work, unfortunately, when he was done, he put a clamp there and distorted the stent. And so the entire stents were out, and you can see only a perineal left. He actually had a dissection at the distal end of his work as well. So here is from a contralateral approach crossing into the distorted stent, but carefully I could not get antegrade into the perineal, and again, later we found out why it was dissected by IVUS. So here's perineal access, so it's a right, so it's an RAO, and here's your perineal access. And again, a support catheter and a wire just like you've seen in the live cases, and we're able to get that up. We then externalize it into the FR4 bright tip and then go up and around. And we're able to complete that both in the distorted stent and then all the way down. Here's another patient who had had 2 attempts at an outside hospital, had occlusion, and then a lot of disease, occlusion throughout the popliteal. He also had a PT occlusion, so we went peroneal here, again, with the oblique angiogram, go up retrograde, and we fixed the PT as well, and this from an antegrade approach once we had crossed from the peroneal approach. And this is what it looks like when you're done. I mean, it doesn't hurt the peroneal artery. This is one Andre came to Kingsport. It was really pretty fun to work with in person. This is one that had 3 endo attempts, failed an outside. Came to me, I failed a 4th time. I came close, and we saved it for a live case. They had a bypass that also was down, and it was occluded throughout all this, reconstituting the peroneal. The posterior tibial actually came back only through geniculate, as you see here. So here was our antegrade approach. We got real close, but all we could do is get into this PT collateral, not in the true PT, and couldn't direct it towards the anterior. This is Andre getting this access, what I like to call the yaw approach. He simply hit it in 1 second and said, yeah, I think we're in, and he was. And then, again, as you've seen, balloon, externalize, and finish the live case. And the very last one, again, you can see very long disease here, occlusion of the popliteal artery, occlusion of the trifurcation, but you do see the peroneal. Guys, peroneal is an accessible vessel, and so here's accessing it, taking your catheter, going retrograde, externalizing, and finishing. So, in conclusion, peroneal access can be very helpful to successfully complete challenging endovascular interventions. A strategy of micropuncture access guided by fluoroscopy and angiograms from above and use of low-profile stuff from below can be very helpful for these folks. Thank you very much for your attention.